Hello, my name is Paul Helland. I'm one of the anesthesiology residents here at UCLA Medical Center, and today I'd like to go over how to set a room up for a general anesthetic, a question that we often get from our awesome rotating medical students. Alright, just like previous videos, the contents are going to include some introductory thoughts, an acronym that we use to set up a room called MSMAIDS, some important accessories to consider, and some conclusions. All right, a couple of introductory thoughts. It's important to develop a system for setting up a room that you can rely on. The one we're going to go over today is based on a classic acronym called MSMAIDS. I want to put a couple caveats here that are very important to keep in mind as you proceed with your training. The first of which is, do not use drugs that you're unfamiliar with, ask for help, and do not use equipment that you're unfamiliar with, ask for help. Also, to the best of your ability, always maintain a clean work environment. Now sometimes things are going to get a little hairy in the OR, bleeding, cardiac arrest, all sorts of catastrophes can go down where it becomes a giant mess, but once things calm down, always take a moment and clean up your workspace. So what does MSMAIDS stand for? It's an acronym to help remind us of all the things necessary for a complete room setup. The first of which would be machine, then suction, monitors, airway, IV, drugs, and special. And we're going to go over each one of these things in great detail momentarily. Before we get into the nitty-gritty of MSMAIDS, right when you walk into the OR, you're going to see some version of this whiteboard. And if you've seen any of the other videos that I've done, you'll know that I emphasize introducing yourself to the person that's in the OR. Usually the circulator nurse is there first. You can ask them if you can write your name on the board under anesthesia as visiting student, and then you can move on to MSMAIDS. So this is what you usually see when you walk into the room first thing in the morning. Machine here, Pyxis over here, I don't know, some equipment tray over there, a chair here, patient table here, and we're going to see how MSMAIDS will help us transform this into an area that is ready to provide anesthesia for our patient. So first things first, the very first thing I do when I walk in and start my room setup is I put down 2 blue towels, one on the table attached to the anesthesia machine and one folded on the Pyxis machine, and I designate these areas as dirty and clean. In other words, this is the area that will be for this particular patient that we're taking care of. And if I happen to have drawn up clean drugs that I did not use on the patient or pulled out equipment that remained clean that never touched the patient, I leave it on this side. I never ever take something that is placed here and put it back over here. I separate these areas into dirty and clean. Plus, I'm a sucker for blue towels. I think they look nice. Okay, the first M in MSMAIDS stands for machine, and we're going to go over all the components necessary to run a machine check to make sure this is up and running for us to take care of our patient. Let's go. First thing you do is find the on-off button, press it, it will make a noise, and then the screen will flash. Okay, once the machine is on, you'll see this screen. Now, for the record, we're going to be talking about the Draeger Apollo machine because it's the most common one that we use here at UCLA. We have a few rooms that have the Ferrari version of an anesthesia machine, but since most of us drive Camrys and not Ferraris, we're not going to talk about the Perseus, and we're going to stick with the Apollo. This screen here will walk you through step by step on how to do a machine check leading up to the self-test, and we're going to go through each one of these components, starting with the gas supply. Notice that this will tell you not only what the pipeline pressure is coming from central supply, which should be greater than 50, but also will tell you about the cylinder pressures from the backup supply on the machine. One thing I want you to take notice of is the pressure of the nitrous, which seems to be a bit low. So number one, it's telling us, go open the cylinder valves to check the pressure, then close the valves after the check and see if these numbers have changed. So let's do that. Located on the back of the anesthesia machine are 3 cylinders for our backup supply of oxygen, air, and nitrous. Let's see how we open up each of these valves like the machine told us to see if it can register the pressure that's inside each one of these. All right, in order to open up each of these canisters, you have to have a special key, and that key usually chills right here in this little slot. You'll see that I'm holding the key in my hand here. This little hole here goes over the top of this little part here, and it's oriented both in a horizontal and vertical direction just for ease of use. And then it's righty-tighty, lefty-loosey. I have a video here that illustrates exactly how to apply it, turn, and one thing I want you to pay attention to is the pressure gauge on each one of these canisters to see if it moves when I open up the cylinder. There it goes up, closing it off, and notice that the pressure stays up. Goes up, barely moved a little bit, and stays up. Same thing with nitrous. Notice that it went up, and when I close it, it stays up. Now, these pictures are from a different time that I opened just the nitrous to illustrate the same point. Now, when I first came in the morning time, I took a picture of what the nitrous cylinder pressure was being read as 421, which again seems a bit low. When I opened it up in the back, it shot right up to right where it's supposed to be, towards about 750. So when you come in the morning time and you see the cylinder pressure super low, before you go and diagnose an empty cylinder and you bother the anesthesia tech to come bring you one, make sure that you use that key, open it up so the pressure inside the canister registers with the machine and reads accurately, then come back to the front of the machine to see if the pressures are now more on par with your expectations of just how much pressure should be in each of the respective cylinders. Let's move on to the next step, which is finding this O2 flush and this auxiliary O2 flow meter, whatever those things are. So number 2 is asking us, is the O2 flush functional? There's a green button that sits right here that is called the oxygen flush, and if you press it, it can blast anywhere from 35 to about 70 liters a minute of oxygen emergently. And you can press this and notice immediately whether or not it's functional. The next thing is the auxiliary O2 flow meter, which is this guy here, just to the side of here up in this picture. And all you have to do is turn this knob to the right or the left and to turn it on and off. And this functions basically like a Christmas tree that you see on a ward or in the PACU. The next step, number 4, is asking us, are the breathing hoses connected correctly? Now in the back of the machine coming from Central Supply are these hoses here, and it would be very unusual for these to be disconnected, but it's a good idea to just visually inspect to make sure that each of them are secured tightly, and here they are. Moving on to 5, 6, 7, and 8, the vaporizer portion of this checklist, we start with number 5 that says, are the vaporizers correctly locked in position? And each one of these things can be removed, so just giving them a gentle pull can help you ascertain whether or not they're locked into position. Are they all set to 0? You can see here on our 3 more common vaporizers, DES, ISO, and SIVO, that all 3 of these are set to 0. Are the fill levels okay? And this can be seen by this zoomed in picture of this little vial here. And this meniscus right in the middle, if this were full, should be at the top. So this suggests that this vaporizer needs to be filled with more volatile agent. Lastly, is the safety fillers locked? These 3 guys here need to be screwed in tight. This particular one doesn't get screwed in though. You have to push this in. It's a pin mechanism. As long as all 3 are locked into position, then 5, 6, 7, and 8 are ready to roll. Okay, so the next steps are regarding the breathing circuit. So let's talk about steps number 9 and 10 first. The breathing circuit being fully assembled and if it's correctly connected. The breathing circuit itself comes in this little bag, and when opened up, you can see the various components. The first of which is a gas sampling line, a tube that has an inspiratory and an expiratory port leading to a Y connector, as well as a breathing bag. And these are connected, fully assembled here. The expiratory and inspiratory limbs are supplied here, and this little Y piece eventually is going to be connected to the mask. However, for machine check purposes, it will be plugged into this little nubbin that we'll go over in just a few slides. The sampling line itself connects not only to this little blue part here, if you can see this on the Y part, and then it travels over to the water trap, which again we'll go over in just a moment, and screws in here. Okay, steps 11 and 12. Read, is the gas scavenger connected and the flow adjusted? And that can be found here on the left side of the anesthesia machine. And you'll notice this little orange nubbin with these two black lines. And if the gas scavenger is functioning correctly, this little ball, this little orange nubbin will sit between these two lines. Next, it's going to ask about the CO2 absorbent being okay. That's found just on the underside of the anesthesia machine, right below the table. Usually people will place a date on when it was last changed, and you can get a feel for if this needs to be changed depending on the color of it. If it's extremely purple, or once the patient is connected to the machine, if you notice that the CO2 does not return to 0, it might suggest that the CO2 absorber needs to be changed. Okay, steps 13, 14, and 15 ask about the water trap level being okay, and as discussed previously, this is what the water trap looks like with the sample line attached to it. This has just barely a little bit of water in it, so it should be functional for the next case. If you start to get a warning that the water sample line is being contaminated or the fill line gets excessively high, it may be time to change that. 14 asks you if the suction's okay, and we'll go in ad nauseum about how important suction is in just a moment since it's part of our MSMAIDS acronym. 15 is asking us about our emergency resuscitator being present, and of course it's referencing the ambu bag, which at our facility usually either hangs on the back of the anesthesia machine or in this case on the side of the Pyxis. All right, the next tests are going to ask us to prepare for the self-tests. 16 says close all the flow control valves, which are these guys here. You'll notice that these are closed not only because the screen itself will tell you whether or not the flows are running, but this little bobbin here will stay flat if there is no flow. So once you turn these flows on, this guy will raise up. So two indicators that these are completely off. And of course, going to the right towards the minus sign turns them off, and vice versa turns them on. Next, it says to occlude the Y piece. Now I mentioned a few moments ago, this Y piece here eventually connects to the mask. However, here's the picture of that nubbin that I talked about with the Y piece attached to it. And this thing solely functions just to assist us in occluding this particular part for the machine test. Next, it's asking us to connect the sample line, which, as I mentioned, connects to this little blue part, which you can see here. The blue part has been unscrewed and has been screwed into here, with the other part being connected to the water trap. Okay, the next part's going to ask us about the APL valve check, or the adjustable pressure limiting valve check. It's going to ask us to set the APL valve to 30, which you can turn this dial to set to 30, to then press the oxygen flush valve until the pressure stabilizes. Then you can squeeze the bag to see if it exceeds 45, and by releasing the flush valve at the time, the pressure should not fall below 15. Then when you open the APL valve completely, the pressure should fall back down to 0. Now this is going to be a little video that will illustrate setting it to 30, squeezing it, demonstrating that by setting it to 30, it does not surpass 45. But it will not show the portion where I release the oxygen flush valve and then the pressure should not fall below 15 because I just opened up the valve right after. So let's take a look. So here I am putting it to 30. I'm pressing the oxygen flush valve. You'll notice that the bag is inflating. I'm going to give the bag a squeeze. You'll notice the pressure monitor on the screen is showing that when I squeeze it, it does not go beyond 45, and it drops completely once I open up the APL valve. Once you've gone through all those steps, all you have to do is hit this self-start button, which is just right here. The picture was cut off. And I know this seems kind of cumbersome and arduous. However, you get pretty fast at doing this once you've done it a few times. Next, S in MSMAIDS stands for suction, and you'll notice on the left side of the anesthesia machine is a suction canister that's connected. This little red part here is in direct connection with the suction power from the wall, connects right in the middle. This tube here connects to a rigid tip catheter, also known as a Yonker tube, and there's several other ports for other things, and you want to make sure those are capped off if this is the only thing that you have connected to it. The on-off switch on this particular one is right behind the suction canister. Right now it's off. All you have to do is turn it to the right to have it on. And there's so many different places to store suction. I happen to just bend it right at the tip where it's connected to the rigid tip catheter, and then just tuck it right by the desflurane vaporizer. And again, your mileage may vary. Okay, I tell all my medical students when we're going through the machine setup in the morning time, where's the suction? And they point to it, and I say, let me hear the song of its people. And then they usually stare at me and they go, what the hell did you just say? But what I'm really asking for is, I don't just want to know that we have it connected. I want to know that it's actually on. So when we need it and then we grab it from wherever we're storing it, we know that it's already on and we can use it in emergency conditions. So this slide here was inspired by my dog, who, at the sound of even a whisper at the door, will sing the song of her people and bark like crazy. So whenever you're setting up suction, make sure before you tuck it away that you've demonstrated to yourself that you can hear the sound, that beautiful sound of suction. Okay, the next M in MSMAIDS stands for monitors. And I want to remind you guys that the ASA Standard 2, in terms of their basic monitoring statement, is as follows. During all anesthetics, the patient's oxygenation, ventilation, circulation, and temperature shall be continuously evaluated. And it can be found in this link here. And for exam purposes and for practical purposes, I just remind myself of OVCT, and then reminds myself of oxygenation, ventilation, circulation, temperature. So for oxygenation, we'll use the pulse oximeter. For ventilation, we'll use continuous capnography. Circulation, we'll use blood pressure, whether it's invasive or non-invasive, plus the ECG. And for temperature, we'll use a temperature probe of some kind, whether it's skin, esophageal, attached to the Foley, a swan, an axillary. There's a billion places you can monitor temperature. Other monitors to keep in mind, though, however, include the twitch monitor if you're using paralysis. And we have both the old school and the new school ones available, and I'll discuss what that means shortly. Okay, let's talk about some tips on where to find this stuff. So on the anesthesia machine, there's two drawers. The bottom drawer is where you can find blood pressure cuffs, pulse ox, and even an old school twitch monitor. So here's pulse ox for different ages and different size blood pressure cuffs. And the top drawer is where you'll not only find the volatile agents, but some water traps, a backup flashlight, some sample lines here, and importantly, the ECG electrodes. The Pyxis in the third drawer is where you will find the esophageal temp probes, which are here. I do want to point out also that the backup airways, if you're utilizing a endotracheal tube as your primary airway, are also found here in the back, and I will reinforce this later on a different slide. Okay, so one thing I want to point out is a special monitor that we use at UCLA, and it's called a Philips X3. Now you'll find these guys inside the pre-op area attached to the patient, and when we bring a patient back to the OR, we take this with us, and then once we get into the OR, we plug it into this area here. The rest of the monitoring cables, which with the X3 plugged in here, are usually found hanging here, anywhere from stuff for an A-line or a swan, or the neuromuscular monitoring if you're using the new school version, of which I'd like to point out here and here. This is the neuromuscular monitoring that's based on accelerometry, where these two leads, much like the old school one, are placed in the whatever nerve distribution, most commonly the ulnar, except this guy here is attached to the fat pad of the thumb, so when the monitor stimulates the patient with a train of 4 or whatever type of stimulation you're using to evaluate paralysis, will cause the thumb to twitch. And just like your iPhone, when you take it from a horizontal, or pardon me, from a vertical to a horizontal, there's a accelerometer inside that detects when you've changed orientation, This machine here can also detect when the thumb is making movement from stimulation of whatever nerve that you have it attached to, and it will register that both as a train of 4 in terms of just gross number of twitches, but also a train of 4 ratio. Super helpful. Unlike the old school ones, which rely mostly on the clinician observation or feel, which have again not been shown to be as accurate as the accelerometry. Nonetheless, they're there for backup because on occasion these things can get finicky. All right, the next letter in MSMAIDS stands for Airway. And there's a variety of things that you need to have, at least to keep in mind when it comes to the airway. And it's not just as simple in my mind as an endotracheal tube. To start, you need an endotracheal tube if you're providing a general anesthetic with an ET tube, along with a stylet. These can be found in the 4th drawer starting from the top, along with the handles here, the blades underneath them of different sizes, the stylets sitting here, and then the different size ET tubes here. So oftentimes we use a 7.5 for men and a 7 for women just as a general guideline, but this can change depending on the size and height of the patient. A 10 cc syringe is necessary, which can be found on top of the Pyxis because we need something to inflate the pilot balloon. You obviously need a handle and a blade, whether you use a Mac or Miller, just depends on your preference. You need to have a mask to attach to the circuit at the Y piece, which was mentioned earlier, which can also be found in the same drawer here. An oral pharyngeal airway is often useful to have on standby, which can be found here if the patient proves to be a difficult mass ventilation. A bite block that you can take a stack of gauze and wrap tape in it, or you can just use the OPA airway, which is rigid enough to be a bite block. Tape itself, not only for the eyes, but also for the tube itself once you place the tube in. Now I put the esophageal temp probe here because it reminds me of something else that goes into the mouth, or, quote, the airway. Even though it sits in the esophagus, it just reminds me to have it there, since as soon as the tube is taped, I throw the esophageal temp probe in. And one thing, a part of the airway, which I want to emphasize since this has saved my own patient's life, is know where your ambu bag is, as well as your backup airway. I mentioned earlier that in the drawer above this, in the 3rd drawer, you can find LMAs as part of your backup airway, which are a key component of the difficult airway algorithm from the ASA. Also, don't forget that your stethoscope is a part of the airway. It's very embarrassing and happened to me several times where I intubate somebody and my attending goes, "Okay, cool, so you have breath sounds on both sides?" And I'm like, "Oh crap, I don't have my stethoscope." In addition, having face mask airway for once the patient is extubated can be found in the same drawer here in the corner usually. And also to know where your Christmas tree is and have it nearby. By the way, tape itself, you'll see this green standalone drawer. Usually in the 4th drawer, you'll find the various types of tape. And we'll talk about what a Christmas tree is in just a moment. So here's some of the components that we discussed. The mask that will be attached to the Y piece, the stylet, it's going to go inside the ET tube. You'll have a 10 cc syringe to attach to this part of the ET tube to inflate the pilot balloon to make sure that it's functional. You have a handle, you have a blade. Here I'm just emphasizing the need to know where a stethoscope is, even though this is one of those cheapio disposable ones. Here's your ambu bag, esophageal temp probe for what that looks like. Again, can be found here along with your backup airway with respect to an LMA. And this is the top of the anesthesia machine in different ways that you can set it up. I usually go for something like this, where I put a backup blood pressure cuff, a pulse ox, the Christmas tree, which is this L-shaped metal piece that can hold the corrugated tubing once the patient is intubated while you're taping, or just during the case itself. I like to hang tape just because it's easily accessible, and I tend to put the pink tape directly on the part of the machine that the bag is attached to. That way it's easily accessible once the patient has been intubated, but again, your mileage may vary. Here's a face mask for the end of the case. Same thing here, different types of tape. And in this setup, there's actually a backup airway on top. I find it, though, it's so easy to just grab the LMA if you know where it is, that it's not always necessary to do this. But again, dogma runs rampant in anesthesia, and you might find a provider that disagrees, and that's okay. The next thing that you need to have is an IV, which is the I portion of your MSMAIDS. Now, this is going to sound kind of silly, but when it comes to procedures, I tend to think like a 5-year-old, in that I state exactly in my mind what it is I need to accomplish for a particular procedure, because it reminds me of what I need to get for that particular procedure. And it doesn't matter if I do this with a central line or a basic peripheral IV or an A line, I tend to think the same way. So utilizing this silly approach, if I were thinking about what I needed to place a peripheral IV, I would say to myself, boy, I need a vein. Oh, okay, cool. So that's attached to the patient. Great. Well, I need to be able to see the vein. Oh, okay. Well, if I put a tourniquet on, I might be able to see the vein better. And I should probably clean before I poke a patient. So maybe I should get some alcohol wipes. And once everything is clean, I need to poke the vein. Oh, yeah, that's right. So I should get some angiocaths. And then once I poke the vein, I should probably attach something to it, attach something to the angiocath in order to stop it from bleeding. Oh, okay, great, like bifurcated tubing and caps. And I need to maybe squirt something in the tubing, hopefully before I attach it to the patient so there's no air. Oh, okay, cool, so that means I need to flush. And then once all that's done, I need something to hold it in place, right? So a tegaderm and some tape. And then, of course, I need to clean the bloody mess that I made before anybody sees, and that would be gauze. And it seems kind of like a silly way to think about this, but I've never forgotten, or I should say, I no longer forget items once I've adopted this mindset. And looking at this picture, we have a couple different size angiocaths, a tegaderm, alcohol wipes. We have a saline syringe, bifurcated tubing with caps, and we'll get a closer look at that in just a moment, and a tourniquet. No gauze is present though. All right, so closer look at that bifurcated tubing and caps. This is what it looks like when you open it up. You have to unscrew these guys, unscrew these two parts of the blue caps, and screw them on like so. Blue cap here, blue cap here. This has a saline syringe attached to it because I have now flushed these bifurcated tubing in so I don't give the patient a big air embolus. Once I have that completed, I take all of the aforementioned equipment, I lay the tourniquet out, I stack it all together, and then I take the tourniquet and I tie it over so it's in a nice place for you to just grab and go. And if you do this, you will find yourself in the same position as this young gentleman here, where you go to set up an IV and bam, didn't forget anything. Okay, the D in MSMAID stands for drugs. Now, I'm just going to offer a few comments on a general anesthetic and an otherwise healthy patient who's going to get an ET tube. The following classes can be useful to have. With that said, be aware that there are many passionate individuals and there is a lot of dogma associated with just how the best way to induce any particular patient is. So, if you happen to learn something one particular way with one attending, and the next day it's told that it's either wrong or there's a different preference or a way of doing it, don't get frustrated by that, just roll with it. Part of the purpose of residency is to be exposed to many, many different ways of doing things, and the more ways that you can see how to do things, the better off you'll be. So in an otherwise healthy patient getting a general anesthetic with an ET tube, a pre-med anxiolytic can be helpful, and if you need one, we oftentimes use midazolam, also known as Versed, and plus a bolus of good bedside manner. And I think this is forgotten when you happen to have this in your pocket. Sitting down at the patient's eye level, talking to them in a calm manner, giving them good bedside manner can really help alleviate a lot of the anxiety and might even make it to where you don't even need the Versed. You need a bag of IV fluid. At our institution, this is often provided by the PTU nurses, whom we really appreciate, and we bring it back with us. If not, you need to have this set up in the back of the OR. You need an induction agent. Oftentimes, in an otherwise healthy patient, we use propofol, and if you are going to use it, we also drop lidocaine, which supposedly helps decrease the burn associated with the injection. You also need an agent to blunt the sympathetic response to laryngoscopy, and that can be anything from a narcotic to esmolol to another healthy dose of propofol right before you intubate the patient to many, many other things. Again, it just depends on your attending's preference and eventually will depend on your preference. You need a paralytic agent. Oftentimes we use rocuronium. A narcotic in small amounts. Oftentimes we pull out fentanyl. Once again, there are attendings who would disagree with this completely, but if you're going to pull out a narcotic, a small amount of fentanyl just to get the patient started with incision and whatnot, with the goal of maybe working in some long-acting narcotic toward the end, is not unusual for an otherwise healthy patient getting a routine general anesthetic for whatever surgery, and then having some pressors on standby like phenylephrine and ephedrine, because there are going to be different settings in which you will give each one of these drugs, such as if the patient happens to be bradycardic and hypotensive, perhaps they'll reach for ephedrine. That's that. Okay. Last thing to mention about drawing up drugs is always want to label your drugs, and we have quite a few preform labels for a variety of drugs here at UCLA. Of course, each one of those requires the concentration of the drug, if not already stated, as well as the date and time and your initials of who drew it up. The syringes and the needle tips to draw these drugs up can be found right above the Pyxis. However, we implement one more step in safety here at UCLA, which are these little blue caps. Blue caps can be found in the upper left corner of the Pyxis, or right above the Pyxis. They're called tamper-evident caps here. So when you first drop a stick of propofol, it might look like this, where the needle tip's still on top of it. You will remove the needle tip, open up a package of these tamper-evident caps, and I've picked one of these up to show you what the inside looks like. Once the needle is taken off and the luer lock portion is opened up, you can screw it directly into here, and then it will sit like this secure. And the reason for this is when you see a syringe with a blue cap, this signifies that it has never touched any other patient. Once you need to use this on a patient, you can pull directly on this blue cap. It will pop off, and the inner portion of this blue cap will remain. And that will signal to you not to use this on the next patient, because it's very likely, even if it theoretically has been used on a previous patient. So if you see a syringe that doesn't have a blue cap, it has the inner portion of one, it has to be thrown away before the next case starts. Okay, here's a video of me attempting to demonstrate what I just mentioned. Here I am screwing in the cap on an empty syringe. There it is. I'm gonna pop it off now. Boop. And there's the inner cap staying put. So if you see a syringe like this, you have to toss it. Do not use it on the next patient. Okay, this is less involved with setting up the room, but it's more of a shameless plug for my particular type of organization. So when you have the patient under anesthesia and everything is just kind of coasting, I think it's important to have a system for keeping your drugs in order. And I just want to introduce mine in case anybody wants to adopt it. I tend to keep my downers on one side, my uppers on the other side, and my random stuff up here. So propofol is a downer. It puts people under deeper anesthesia. This is also where I would keep narcotics. And over here we have phenylephrine and ephedrine. This is where I would also keep things like calcium as an inotrope, or vasopressin or epinephrine. Here I would keep things like sugamidex or rocuronium or Zofran, anything that didn't fall in these latter two categories. And having something like this is useful in the middle of a crisis, because I know exactly where to reach for my pressors when I need them, and I know exactly where to reach for my induction agents or a agent that will help put my patient under a deeper level of anesthesia should I need it urgently. And the same thing with my paralytic. So again, just an introduction to a type of drug management system once the case is underway. Last letter in MSMAIDS stands for special. Now this could be anything at all. It could be an A-line or a Cordis if you have a big case, a Swan if you're doing a heart or a liver, rapid transfuser if you're expecting a lot of blood loss, extra pumps, BIS monitor, hotline, ultrasound, SEDline, you name it. It's to remind yourself to ask, is there anything else about this case that I needed that deviates from that of a general anesthetic? Last but not least, a couple important accessories. The first of which is I'm often surprised about how many people do not know about the Stanford Emergency Manual. This is an exceptional manual put together by outstanding physicians at Stanford University that goes over a variety of different intraoperative critical events. And this manual is known as a book of cognitive aids. In other words, when you have something that develops critically in the operating room, like hypoxemia, you can open up to hypoxemia in this manual, and listed in a very easily digestible format is a cognitive aid that can help guide you in the setting of extreme stress. So knowing where your emergency manual is very helpful, especially when you encounter trouble, you call for help. Somebody can easily function to just open that up, make sure that everything has been thought of, appropriate treatments have been initiated. And fortunately for us at UCLA, there's one of these in every single operating room. So I just want to bring this to your attention. You can also download this for free. So thank you, Stanford, for providing this to the world at no cost. It's very much appreciated and highly useful. Also want to know where your trash can is, your sharps bin, and oh my God, you have to know where your chair is. Okay, in conclusion, find a system that works for you and practice it until it becomes second nature. As always, this is my shameless plug for UCLA being a fantastic place to train. I would highly suggest you at least interview here, check us out, and see if we're a good fit for you. I am pretty confident when I say that we can accommodate just about any personality and any professional goal. Lastly, consider pairing MSMAIDS with a systematic approach to assessing a patient under general anesthesia, which is a shameless plug for another video I've made. And as always, feel free to reach out for any comments, questions, or concerns, and take care of yourself.